Dear friends, proximal femur fractures comprising of fracture neck of femur and trochanteric fractures have always created lot of confusion in our minds. Fracture neck of femur in young needs to be fixed, but what is the right way of fixation? What is the right way and when to open reduce them? What is the right implant to be chosen in fracture neck of femur in old osteoporotic fragile fractures and trochanteric fractures when they become unstable, involving the so-called lateral wall fractures, posterior medial fragment, anterior cortex comminution. All these will create a plethora of cases, confusion. Let us talk about them. Let us talk about our own failures. Let's talk about the right way, the minimal requirement, how to fix them, when to replace them. Proximal femur fractures, let's look at them.
What was the takeaway from this module of proximal femur fracture? We have just concluded.
Well, there were many topics, as you know, from femoral neck to the intertrochanteric and subtrochanteric. And I think the takeaway was do the fixation right the first time. And if it fails, then the salvage options were discussed, which were very interesting to see. You can go from revision fixation to replacement.
I think we have also addressed issues of which fragments are critical to be fixed, including the lateral wall. Of course, lateral wall is gaining importance in terms of failure of lateral wall while passing the hip screw. Posterior medial fragment is gaining a lot of importance in terms of its reduction and having bone-to-bone contact by using cerclage wire effectively to wrap up the posterior medial fragment. A cerclage wire wrapped around all the fragments of proximal femur trochanteric area and then doing the intramedullary fixation probably seems to be the way to go. And of course, we ended up effective use of augmenting the primary device so as to secure the primary fixation by using a hook plate to have an external augmentation. Internal augmentation can of course be added by various designs of hip screw and using bone cement technique.
I think to that end, just add to the fact that we talked about anatomic reduction. So like
Yes.
you talked about cerclage wires or clamps or open reduction, but definitely anatomic reduction.
Yes.
So, what is the current state of unstable four-part trochanteric fracture? Whether you would advise replacement or fixation with augmentation?
So I think fixation is the right way to go for intertrochanteric fractures, even if it is unstable. One is allows for natural bone healing and the patient to return to their function. The problem with doing a replacement for a four-part intertrochanteric fracture is that you have to use some sort of either a proximal replacement or you have to do some sort of augmentation for the abductor muscles.
Yeah, so I would also vote for fixation. So if the right fixation techniques which have developed over the period of years now using in-text augmentation, I call it, which is internal and external augmentation together with good fixation should be the way to go. And of course, as we talk, reduction, bone-to-bone contact is extremely critical to make sure that the implant doesn't walk out and everything falls apart.
Sir, what are your ideas about cement augmentation of proximal femoral nail?
I think cement augmentation in the head or the neck is probably the next step. We still don't know how much and who needs it. There are newer devices that allow you to inject the augmentation through the screw itself. We have been doing it outside the screw for a long time, but for very few, very selected cases or revision cases. And I think there it seems to work, but I think it remains to be seen. There's no still long-term or large studies.
I agree. In fact, Nirmal, India is seeing a huge increase in fragility fractures around proximal femur, which tend to be comminuted as well. And of course, these patients are senior citizens. So we are now in fact on crossroads whether operating a 95-year-old lady comminuted, will she survive arthroplasty, or is it better to do fixation and with all these augmentation techniques still give her a chance of a better quality and live more than the desired life? Because we know that arthroplasty creates huge amount of physiological disturbance, big incision, big thing to do. So a lot of physiological changes occur at that age, and if those patients are really able to sustain them. So if it's a reconstructible fracture pattern with all those techniques that we are evolving, even with fragility osteoporotic bones, probably fixation is the way to go, I think.
I agree. I think 95 is getting old, and I think in my hands, I think the oldest patient I've fixed is 107.
Oh, really?
Yeah. So, sir, with the osteoporotic fracture increasing in the Indian scenario, so what do you advise about the osteoporosis management? Do they start at the time of fixation itself, or do we wait for that?
So we typically recommend starting, if you're going to start something like Forteo. But otherwise, we will wait for the bone to start healing at least 6 or 8 weeks before any treatment is started. But anyone who gets a hip fracture is automatically classified as a fragility fracture, which means if they're not getting treatment, which unfortunately most people around the world are not, they should definitely be counseled to start osteoporotic medication. And I think as orthopedic surgeons, we are losing that opportunity because we are the ones who see osteoporotic fragility fracture, that is hip or shoulder or wrist. And I think multiple studies have been done, including from our institution. I think our catchment rate was only 30 or 40%, which is shocking, even though we have a program to allow this to happen.
Yeah, I agree. So in my setup, I start bone building medical treatment. I tend to use now since last few months, since Avinity is available in India now, which is romosozumab. I put all my osteoporotic patients whom I operate on romosozumab, and it's easier. It has got dual action. 1 year of romosozumab, and then switch over the patient to either some kind of bisphosphonate or give teriparatide.
So what sort of weight bearing protocols you advise at your setup? Being this patient, we need to mobilize them early. How do you do the protocols for post-operative patients in your setup?
So my philosophy, and this is the one that I've been very aggressive about, is that anyone who's older, if you cannot let them weight bear, you need to do something else. So if your surgery will not let them walk right away, you need to do something to help you do that. So for intertrochanteric or pertrochanteric fracture, if I'm nailing them or putting a secondary plate with that, the goal is to get them to walk on day 1. Or in that case, they're getting a replacement if they can't walk. Either way is, if they have to be out of the bed next morning.
Yeah.
That's my primary requirement for all fragility hip fractures.
So as a leader of the orthopedic fraternity, what you will advise to the younger generation in terms of an intertrochanteric fracture, how they should get trained, how they should get their patient mobilized as early as possible?
I think it's important for young orthopedic surgeons to understand that trochanteric fracture is never a very simple trochanteric fractures. The incidence of failure is almost 25 to 30% as the age increases. So train yourselves well. Make sure that you make the right diagnosis. Consider doing a CT scan, understand the comminuted fragments, their location, so that you reduce the fracture well before you embark on the journey of putting a guide wire and banging a nail in.
Yeah, I couldn't agree more. I think the understanding the fracture and then the expression that we use is it is not just a hip fracture. It is probably a way more complex injury that is understood. You know, people are not paying attention, like you said, getting a CT scan. And I think that's one of the reasons why the failures are, more than half of them are errors in management, which definitely can be improved upon. And that's where the training and experience comes in.
So how do you guide the junior fellows to go into the research? Which direction should take for the further research in intertrochanteric fractures? Any suggestions?
Well, I think the big hot topic we just talked about is augmentation. I think that's a field that's ripe. The other thing that I noticed, I think we looked at very different types of implants that are being used, and that's an easy study or easy research topic. I think all you need to do is the advantage of being in India is that the volume or the number of patients is so high that most of these studies can be done. It just requires application of somebody to guide you to do it. And I think a topic of augmentation, talking of implant constructs, I think those are easy to look at and can be done. The hard part is obviously follow-up, because you got to find these patients have to come back. But I think it can be done. I don't think it's determination to do it.
So
I think another quick suggestion to young orthopedic surgeons who are out there to train themselves. Nirmal is a great friend and he has got huge contacts in America. So those who want to kind of train themselves with American technology, American system, I'm sure he would find ways for any young orthopedic surgeon to go there, do some kind of fellowship, work under him, observe couple of centers. We also work with IOTA, which is the international part of OTA, and even there lots of observership and fellowship programs are there which young surgeons can look at.
Absolutely.
it was pleasure talking with you, sir, in the Traumacon Studio, and pleasure here. Thank you, sir.
Thank you.
Thank you very much.
Overkill definition, use of an excessive force on action that goes further than what is necessary to achieve a goal. That is the Google definition. Our goal of a fracture treatment is non-union, should not happen, and every time it should heal up. That is our goal. So whatever we do for that is going to be not overkill at all. Kashmir lockdown for 1 year and 6 months, Google. All these are overkill. Overkill is must for the benefit of humanity of the fracture treatment. Do whatever you want to do on day one. Don't wait for the non-union to occur. So I do not hesitate, or almost I would say recommend, almost every fracture except in a real young people, PFN must have either a TSP plate or a hook plate in order to avoid a shortening, in order to avoid a virus, and in order to avoid Z effects or whatever it is. But if you put a nail and a plate on a subtroch fracture, it's an overkill. We are treating another human being, poor or super rich. All attempts at making him normal in the shortest time is our goal. It can't be overkill. This fracture, how will you treat? Gurbinder, if I can ask you.
Chief, for me, this is going to be, it'll require intramedullary nail, but I would definitely put encirclage wiring to reduce it. So I would open it, reduce it, clamp it, then get my guide wire, and then get my
Fine.
foamy.
So this is what it is. Simple treatment. Do not try to do everything close. Open it up, put a circlage wire. You can put in even the guide wire from the fracture, so it will go exactly as you desire to go, and the damn thing heals up. You don't have to be sold out by MIPO giants who are marvelous speaker, but I think they have done enough harm to the orthopedic fraternity. This was a fracture. MIPO people, non-union, similar fracture, circlage wire. It is a little open reduction have to be done in order to get you a stable fixation. But it's not a sin to do an open reduction. I don't know why people feel sold out to this MIPO that we haven't touched the fracture. If I can say, only in a shaft fracture, probably opening it up may delay the union. In a metaphyseal fracture, it doesn't make any difference whatsoever. All this, you know very well on day one, this has opened out. This is going to go into these situations. It broke down. This was an orthopedic surgeon's wife. It's so easily treated. Point of entry in GT, not a positive reduction, but a hook plate, and everything becomes all right. Why not this fracture? If it has happened like this, why not on day one do a plate on that? I would strongly suggest do not advise or do not ask for a PFN alone. PFM, when you ask for, there has to be adjuvant plate, either a TSP plate or a hook plate, which should be asked for. So that on the table, if you have a little doubt, you go ahead and put it on day one. And you will not have to do a second operation at all. This is what I strongly feel. We all try to do a minimum operation and fail in the situation. Again, one operation now. Blade plate. Blade plate, if there is a gap here, unless you fill it up, that gap is not going to function. Blade plate works purely onto the compact bone which is there all the way. So unless you fill it up, it's not going to work. So this didn't work. Second operation, this worked out. And now ultimately, you had to resort to a double plating, nail and a plate. Nail and a plate is a salvage of an orthopedic surgeon. I feel at the smallest pretext, if you feel you have not done a 100% job, go ahead and put a plate. You will never regret. Now this was a fracture, nailing, perfectly nailing done, but you can see this is the piece which is going sequestrated, again nailed, again non-union. So ultimately it had to be treated with the fibula and the plate. So all these situations, probably on day one, if you had put in the plate adjuvant, only thing because you know that it's not a very stable construct because of this comminution, it would have been healed up without any problem. So adjuvant plate on day one would avoid these two extra surgeries. Today I recommend all subtroch fractures which are comminuted are not necessarily stable with nailing alone. I strongly suggest it be treated with the cerclage if it is not useful with the adjuvant plate. See this subtroch, 1, 2, 3, 4, 5, all of them, we have seen them going, all of these could have been salvaged. I wouldn't say all, but quite a lot of them could have been salvaged if there was an adjuvant plate on that, or a comminuted fracture like this. Again, an adjuvant plate solved the problem. On day one, it would have solved the problem. Now this fracture, you can see the comminution. It is in the isthmus. So it's supposed to work very well only with the nail. But with this comminution, again it went into non-union, double implant, it worked. But see on day one, if you see this picture on day one, this is not a good construct. On this day one, if in case adjuvant plate would have done, things would have become all right. Today, I don't hesitate, more so in osteoporotic fractures, doing a nail and a plate on day one. Can this ever heal up? If you are stuck up with the situation where the nail is far too thinner than the width, even in the isthmus, if it fits in this area, since it is wider, it will not heal up. So what's the use of doing this nailing at all? Or this nailing, or this nailing, or this nailing? All of them could have been salvaged after a nailing with the adjuvant plate. So I feel strongly, must do an adjuvant plate. Short oblique fractures, these oblique fractures. In nailing alone, even if you put 5 screws distally, is not going to be stable. So day one, do the plating instead of after 3 months when it goes in for a non-union. Lots of time, I would say almost 90% of the time you will be able to get away with it. Or when the nailing is not a fit here because it's not fitting isthmus, it's not fitting higher up. Ultimately had to be treated with a plate, could have been treated on day one with a plate. Mismatch of a nail width and a medullary cavity. Today, this is Dr. Sangeet's case. I think he heard me at one stage and he started putting the plate on day one. Now this was the fracture. Day one surgery, you can see this is so, there is hardly any stability here. So it gave way. Surgeon did a fibula from here, a piddly little plate, gave him a foot drop, ultimately went down, and then Same thing had to be treated with the adjuvant plate and a massive bone graft. Why not on day one? Day one, if you had put in probably a bone graft here and a plate, things would have been all right. This was again the same way. Fracture, treated, because lipo, we have not touched the fracture, it should heal up. Second surgery, third surgery, fourth surgery, everything is fine. On day one, how I would have treated? I would have reduced it. I would have put in a nail and I would put in a plate on day one, and I'm sure it would have healed up. In conclusion, subtroch fracture, femur fractures come in different forms. If primary nailing doesn't give you stability due to any of the factors, do not hesitate. Adjuvant plate will be a salvage on day one. Don't wait for the failure to occur and then do it. Overkill in proximal femur is not a sin. Thank you very much.
So what type of subtrochanteric fracture needs a plate? Do they all need one, or only specific fracture patterns that you see that you say we should always plate?
Those, as I mentioned to you, where you can put a cerclage and do anatomical reduction. It doesn't need an adjuvant plate. But those which are comminuted, and even if you do cerclage, but you don't get anatomical bone-to-bone contact, they are the ones which they need an adjuvant plate. Anatomical bone-to-bone reduction is the most important part. If it is comminuted pieces inside the weight transmission also, it doesn't occur. If there is a small butterfly which is flowing out, it may not be as stable as a two bone-to-bone things. These are the ones which I feel probably will be salvaged on day one with the adjuvant implant.
My question is there a middle path? In a sense, most of the examples that we have seen, the entry point has been from the tip of the trochanter or lateral. So technically, most of them have been poorly done. That is one aspect. Second is, of course, like you mentioned, cerclage wire. If you get that, that's fine. Is there any role for waiting for a few weeks to see if there is proper healing? If not, then go ahead and graft it and plate it. Or do everybody at that time need it? Because the DHS that was opened also that you showed, that was an epsilon type of fracture. The valgus was not restored, so that failed. So is there a middle path? That's what I'm trying to say.
I work in South Bombay.
Right. We work in the peripheral area, sir.
That's why I'm talking about. So the decision is based on to that. That's what I'm talking about. I work in South Bombay. Most of the people pay me a fairly big amount for a surgery. And if I get a half an inch of shortening, sir, how can I go to my kitty party with this shortening? This is the type of a people, if you're treating on day one, if you fail, is going to be a disaster for your career and for the patient.
Dilip, as Nirmal asked you, when would you do plating, day one or do a nail? My answer to that is, high subtrochanteric fracture always to be fixed by angle blade plate or surface implant, whereas low subtrochanteric fractures can be treated with nail. Maybe in case there is a lot of combination, you can add primarily bone graft.
Low subtroch is very, very good to treat with nailing.
Yeah.
High subtroch is the whole, it's very difficult to reduce absolutely anatomical. You need most of the time an open reduction.
Surface implant.
Surface implant, blade plate.
Sir, with many of the failures which you have shown, there is a big lesser troch, that is the posteromedial fragment which is lying unattended. So possibly would the results would have differed if that lesser trochanter would have been attempted to fix. Because now there is a growing interest about the size of the lesser trochanter and its fixation imparting stability to the proximal femur.
I think you and me have argued again in past about the lesser trochanter. You have been sold out on lesser trochanter. I have not been sold out on lesser trochanter. I feel the lesser trochanter is not that very important to refix it, because it's a traction injury, and you have never seen a non-union of a lesser trochanter.
But
We may agree to disagree.
I agree to that also. but it's a fairly big chunk of bone, and you just can't ignore it.
Thank you, friends. Anatomically, if you want to reduce it anatomically, you'll have to go to a posterior approach because it goes posteriorly. And in order to reduce it, you'll have to go down, fix it up properly, hold it up, and then put a cerclage wire or a leg screw. When we do it from the lateral approach, we do a radiological alignment of a LT, but still, if you take a CT scan, it is still rotated. So you do it. I've done it in past for so many times when you do a THR for a IT fracture. You go there, fix it up. Now you reduced it 100%. Now you go ahead and do a replacement.
So this is what we are trying to avoid. All of us here, we are trying to avoid shortening, offset, non-union, and of course varus. And the implant definitely makes a difference, but it is of course the reduction that's going to take care of it. We have all been talking about lateral wall, but please remember the lateral wall is not only what you see in AP, but it's a three-dimensional measurement of lateral wall, most often assessed on a horizontal plane. So remember that it's not a static AP plane conclusion. Let's look at a couple of examples. So what we have been doing for comminuted subtroch is we would bang in a nail, we'll put on a screw, and we will think that okay, all those comminuted fragments are fallen back into place in AP and lateral. So long nail with a long cantilever going beyond isthmus, and you lock it proximally, and you always believed that it's going to stay. Or if there is a comminution proximally, you'll just put some kind of a cerclage wire there, achieve reduction, good bone contact, and bang in the nails, just wrap it around biologically. Or when the CT scan came to our rescue, and we started understanding use of CT scan in the proximal femurs, that would tell us where the comminuted fragments are, and then again you would put in a nail. And that was a time when we had no clue where the calcar should be or the medial calcar should be. So that was the time when we were still talking about positive and negative reduction. Here's a negative reduction, which is the neck going within the intramedullary canal. Is this okay? It went into varus. Fortunately, the patient was young. Fortunately, the calcar stopped at the broad nail. And so two things saved all of us that time. One was, of course, because we did not lock it, the screw migrated out. The hip screw migrated out. The calcar touched it. And the second thing was, since calcar touched the broader nail, it did not go further, and by that time the fracture healed. So this happened in almost 70% of the cases, and for all of us it became a habit and acceptance scenario. Then came an entity called as unstable trochanter. We all talked about it. We wrote about the lateral wall, we talked about the posterior wall, and of course we started talking about internal and external augmentation and various ways of augmenting the unstable trochanter. So either internal augmentation, which can be bone cement, which can be hip screw design, or a medial calcar, or external augmentation. Cerclage wiring, of course, we have two ways of doing cerclage wiring, and we'll talk about it. Either it can be a wrap-up cerclage wiring or wrap around cerclage wiring. And what is that? Which fragments are very critical and what should we accept as acceptable reduction is what we are going to look at. So that's the fragment which we are looking at, which will be wrapped up by the cerclage wire, and that will be a wrap around cerclage wiring technique. And of course, if it's only an avulsion fracture of lesser trochanter, we all have accepted it. But if that trochanter, lesser trochanter fragment is big and extending into the posterior wall, and if it is more than 50% of IT area, that is an important fragment and that must be fixed, and cerclage wiring is an effective way. So Tanna sir, I am trying to put this debate to conclusion that with avulsion fracture, neglect it. type 2 or type 3 lesser trochanter extending into posterior wall must be addressed. And the best way to address it, of course, is cerclage wiring. It's associated with quicker healing, better functional result, fewer complications, and that's what we are talking of. CT scan will tell you how big that lesser trochanter fragment is, how much it is extending, and these coronal plane fractures, more so on the posterior side, will benefit from cerclage fixation. Of course, it's safe, it's minimally invasive, must be done biologically, so please consider doing that. We must achieve reduction before nailing and do it in a very systematic way. So if this is the fracture, which is again a combination of high and mid subtroch, you reduce it well, do cerclage wiring, and then bang in your nail. So this is a just wrapping up of that segment. Long spiral oblique fractures will be benefited by this, and once you do that, all the high subtroch will have good union with only one cerclage wiring, and this is a wrap up cerclage wiring. So 1 or 2 loops, you are just wrapping it up, creating bone contact, wrap up. Innocuous looking X-ray, you do a CT scan, vertically slit, there is no way you can use a surface implant. What you want to do is, you want to wrap around cerclage wire and bang in a effective intramedullary nail. So here it's a wrap around technique of cerclage wiring, because you are biologically also looking after the abductor mechanism to avoid that post-operative lurch or abductor limp to these patients. Once you do it a biological way, it will fall into place. That figure of 8 is going to engulf almost all the comminuted fragments present anteriorly or posteriorly or posteromedially, and give rise to a good solid construct proximally, not allowing your primary hip screw fixation to walk out from any window that might be present once the patient starts weight bearing. Another quick example, you will see on CT scan where the location of the fragment is. You do a wrap around technique of cerclage wiring, wrap around your all the fragments. You can actually demonstrate that that cerclage wire is engulfing not only the anterior cortex but also the posterior medial fragment, and your nail is well secured inside all those commutator fragments without any further collapse or without that head walking into varus. What we want is good bone contact. So good bone contact, if you achieve, if all the comminuted fragments biologically get in touch with each other, it will decrease the stress on your primary implant. It will decrease the pain. You can offer patients early weight bearing and also prevent shortening and abductor lurch. So what fragment is important? Posterior medial fragment is extremely important, and what we should do also is look at the anterior cortex. Anterior portion of trochanter is a tough bone. Once we achieve good anterior bone to bone contact versus posterior bone of trochanteric region is a very soft cancellous bone. Once you achieve good bony contact anteriorly and medially, the collapse will not occur. It will not go into varus. What should we do? There are 3 types of reduction that you will have. Either an extramedullary calcar position, which is seen on the left top, which is the positive reduction, or what you see on the right top is a negative reduction. What we should always have is not this, but this, which is a positive reduction or an absolute smooth medial contact. How should we do this? Is on lateral, try to feel the bony spike, try to feel the reduction, and once you reduce that bony spike in lateral and achieve good bone contact, that's your anterior reduction. That will allow the proximal fragment to rest against solid bone of distal fragment anteriorly. So you don't need to really look at the posterior reduction. You just have to make sure that if the good huge fragment is present posteromedially, reduce it biologically. So that's your trick of anterior reduction, and once you do that, your nail is again secured. So now the concept is do a CT scan, do close reduction, take a lateral view, make sure that anterior cortex either by palpation is reduced well. Many ways to do that. Either use a hook to reduce that anterior cortex, or a simple way is this joker elevator, which can be pushed into the fragment in a lateral view and just sweep that joker elevator. The entire sagged distal fragment posteriorly will come up and it will be a good lateral reduction. Another technique which has been described is this hook lever technique, wherein that hook is inserted in the distal fragment and then you just sweep it and the proximal fragment will come up. So that's this is a neat technique to know. What you must do is try to reduce in lateral view and make sure that anterior cortex is reduced well. Once that is done, once the positive reduction is there on the medial calcar side and it is in slight valgus, it will be effective against predicted shortening. So that's what happened, and that is what is absolutely not acceptable today if you are using an intramedullary device. If you are using DHS, maybe it was acceptable because this was what Diamond Houston technique was, wherein you accepted in DHS or a surface implant a negative reduction. Quick word about bifocal fracture. Couple of comminuted fragments at proximal reduction. You reduce it well, make sure that all fragments are into place, and then for such fractures you can use a DHS with a TSP and it will not collapse further. Another example, this is actually Nitin's case, comminuted fragment. CT scan is showing where the location of comminuted fragment is. This actually had a huge posteromedial fragment. You see there, what you need to do is reduce it well, put a wrap around cerclage wire, and then here you can use an angle blade plate. So same implant, you can demonstrate that your cerclage wire technique is holding all the comminuted fragments in the proximal region well, and that posterior medial fragment is engulfed and is securing the primary device. Comminuted fragment, comminuted intertrochanter with subtrochanteric extension, again very well seen on CT scan. So CT scan is extremely valuable, especially if there is a comminution in proximal fragment. Here again a huge posteromedial fragment. If you only see the X-ray, it will be seen as a tiny lesser trochanter, but CT scan will tell you how big that posteromedial fragment is. There is no way you can neglect this posteromedial fragment. What you need to do here, of course, I used a lateral position here and used an overkill method which is promoted by Tanna sir. So an intramedullary device with a primary fixation of a hook plate, and of course you can fix the posteromedial fragment by cerclage wiring, but secure all the comminution at proximal fragment with an additional hook plate. I'm going to skip this position on X-ray in lateral position, but there's more to the story, because I think with use of bone cement which can be injected and create a internal augmentation, I think that way we can have an internal augmentation also in addition to the external augmentation by using a hook plate. So just to wrap up, whether long nail or a short nail in comminuted trochanter fractures, prefer a longer nail, but the problem is shorter nails of course has a huge incidence of peri-implant fracture, especially in osteoporosis, but longer nails probably have increased blood loss and longer operative time. Whether to use a double screw helical blade or a single screw, I think almost everywhere helical blade is out. Nirmal, US as well, helical blade is out. we are preferring single screw use. Helical blade is out because of its higher failure rate. Dual lag screw versus single screw. I think single screw is better, but an intertine kind of design probably is scoring well in terms of its internal augmentation and a better purchase in the femoral head. Segment augmentation is picking up for most of the osteoporotic fractures. Thank you very much.
Sir, one little apprehension for the superior loop, which we do for GT, it is inside the gluteus medius, not on the bone. So on long term, will that hamper the abductor?
In fact, it restores the abductor mechanism well. And I mean, you have seen all our patients, they don't get abductor lurch because you are pulling the trochanter down, you are securing the abductors. And of course, if you do not go beyond that magic number of 5 centimeters from the tip of trochanter, you are not damaging gluteal nerve. So you're okay.
Actually, it should be flush to the bone.
Yes.
In the trochanter. Then you are not cutting through. Don't go intramuscular. Go
Yeah.
flush to the bone.
True.
The lesser trochanter is fractured, though it is not part of the posterior-medial banana. That lesser trochanter has to be reduced because we are neglecting that lesser trochanter can come back and attach. But that void will allow the early collapse. Even if you have, and on table, if you have reduced it, anteromedial reduction, in spite of that, it can collapse. I have 4 cases anatomically reduced, but they have collapsed later once patient starts walking. So that void is also equally important to bring that lesser trochanter by your wrap-up technique or what we are doing it.
I think we can close the session. Time for the next one.
Thank
Thank
you.
you, everyone.